So welcome, Gina. Thank you very much for taking the time to be able to navigate the technology to present this to us. Off you go.
Thanks, Jane. Yes, it's a little bit different to what I'm used to, but we'll see how we go. We've also got some drilling going on in the background at some stage, so I hope it doesn't kick on. As Jane said, I look after the transfusion laboratory at the Royal, and I've been here for many, many years, probably 28 years. I started at the Women's Hospital in Victoria and went to the Alfred Hospital and then stayed here for a very long time. So I've been rather lucky in knowing obstetric hospital has lots of antibodies, the trauma hospital, which the Alfred is, has lots of. Thanks. All right, they've just told me they've stopped the drilling. That's a bit of power. So the Alfred Hospital has lots of trauma, and in Tasmania at the Royal Hobart Hospital we have a little bit of everything. It's a very, very good learning area. So what I want to do is just go through all of the things that we know about blood and blood products, but when you're working in the lab, the actual cross-matching and getting compatible blood is really a minor part of our role. We have so many other things to look after. So when you go and donate your blood at Lifeblood now instead of Red Cross, I still can't quite get used to the name change. Now you go and donate your whole blood, and it can go into red cells, which are all leukodepleted. You can get a bag of plasma off it, which is immediately frozen. If you want paediatrics, if you're a paediatric hospital, you can then divide that bag into 4. So you can get paediatric sizes in everything. Oh, don't you drill? Sorry about that. But you get the memo. So then you've got your platelets and your other fractionated products. Oh, how bad is that at your end?
It depends on how long they go for. We can hear you over it.
All right. I'll just move. I don't even know where the microphone is. I'll just move closer and hopefully they'll stop.
Yeah.
It's pretty random. So with all those blood products, you make your FFP, your plasma, your platelets, you get cryodepleted plasma. Anything that's not used then goes off to CSL at the bottom as fractionated products. So there's really no waste at all. So the first product that we usually get is a bag of platelets. It's a fresh product. God, it's banging everywhere. Don't renovate a hospital. Platelet concentrates, they are usually about 350 mils, and they're pools of 4 donors. So sometimes in transfusion we consider donor exposures. Having worked through the 80s with HIV and the blood supply, we were always trying to reduce donor exposures. If you could reduce donor exposures, then the risk of getting any viral contamination was a lot less. So this platelet concentrate is 4 donors, and all of them are filtered to remove white cells. They can contain a small number of red cells, which means that you can make antibodies to them, and they are irradiated to reduce transfusion-associated graft versus host. So just a quick thing on transfusion-associated graft versus host. A blood donor, by definition, is healthy. So you can see the healthy lymphocyte can recognise sick lymphocyte as foreign and go in and kill it off, whereas the immunocompromised patient has no immune system to recognise. If the immunocompromised patient was healthy, you'd get a recognition of the incoming lymphocyte. But when they're immunocompromised, the good, healthy lymphocyte in the blood pack can then kill off the donor. There really is no comeback from that other than probably a bone marrow transplant, and they're already not healthy. So the best thing to do is to make these lymphocytes incapable of dividing, which they do by irradiating. So irradiation still leaves the lymphocytes in there, but they can't divide. Yes, they are leukodepleted, but it's 99.9%, and you don't need many lymphocytes that can divide to make it a problem. So you want it to be irradiated if you're immunocompromised, which is high-dose chemotherapy, some drugs, and preterm neonates. The irradiation causes slight degradation of the red cell membrane. So after they're irradiated, the expiry date goes from 45 days down to 14 days post-irradiation. So no problem with everybody getting irradiated blood, but it's a logistical problem and a stock control problem. If everybody had irradiated blood, then you'd only have a 2-week expiry on your blood. So it's all irradiated platelets because most platelets go into immunocompromised patients. And the really only reason what you want to use platelets is to correct thrombocytopenia or patients that have abnormal platelets. There are quite a few drugs on the market, the most common one being aspirin, that will cause platelets not to function. So if a patient's been on aspirin and is going to theatre, they may need to cover with platelets so that they don't bleed during the surgery. And there's some other drugs, clopidogrel, and quite a few more on the market now that are making inroads into platelets not aggregating. And if people are bleeding a lot, usually because surgical bleed or in a trauma situation, you may have to give them without actually knowing what their counts are. So usually you've got, there's a defined amount of platelets. It's 240 times 10 to the 9 or 2 times 10 to the 11, whichever you fancy. And an increment is considered 5 to 10, an increase in a standard 70 kilogram adult. But that can be 100, it could be 10, as long as there's a slight increment, then you consider that the platelets worked. So as I said, you use them for thrombocytopenia, functionally abnormal platelets. You can give them prophylactically to patients with rapidly falling counts in chemotherapy. If you're on chemotherapy and your platelet count drops below 10, then you'll get a platelet. The last thing we want is a spontaneous cerebral hemorrhage. That's really not an ideal situation. And if the patients are febrile, then they have a slightly higher threshold of 20, and then we'll give them a platelet if their count drops to 20. So you need to know what the counts are. If we get a request form and it just says platelets, we need to find out why this patient is having platelets. So that's something that you need to question all the way along when you get a request for a blood product is work out why they need it and do they actually need it. And if you're not sure, then go to the next level to your medical staff and get some help. In a post-operative situation, you may also need a higher level of platelets because you need to help that with wound healing. But you don't give platelets if the bleeding is absolutely nothing to do with platelets. Okay, which is why I said always check. We get a request for platelets and you look them up and it says the platelet count's 250. So then we need to make a phone call and say, why do you want platelets? And they'll say, oh yes, they're on aspirin. Well, those things are handy in clinical notes. Also, sometimes they're just not quite sure what to ask for, so they just check. And if we get ones that we think are odd, we will take them out to our medical staff. Or they're not effective in ITP. A platelet person with ITP with a platelet count of 5, give them a platelet, it'll be 5. You give them another platelet, it will be 5. So you really get no effective use out of a platelet. The only time you would give platelets to an ITP person is if they were actively bleeding. Then you may get an immediate response, but they certainly don't hang around. So all blood products have side effects and hazards. You can get chills and fevers and allergic reactions from the residual white cells that are in there, allergic reactions to the plasma proteins that are in the packs, potential for disease transmission. HIV is taken out of the blood supply. We've had a few other viruses come in. Luckily, coronavirus doesn't go via the blood supply, but we don't know what the next virus will be doing. You can get alloimmunization. That's from the slight red cell combination. And you can get, immunized to the platelet antibodies as well, the platelet antigens. So, and it can cause graft versus host disease, which is why we irradiate them. So usually a platelet transfusion in our hospital anyway, most hospitals, is 1 unit per transfusion. They're a large bag. You do get people asking for more, and those things you need to query. Oftentimes with someone with a low platelet count, they'll ask for one, which should always be given, if they're going for surgery, should always be given immediately pre-procedure, because then you're going to get the maximum use of your platelet. If you get it 2 hours early, the platelets may not be in circulation as well anymore. So it's best to give it immediate procedure. And then we always have another one or two, depending on what they're having done, for just in case. So you do need to look at your stock control and check that you've got enough platelets. But if you give them too early, they're not going to be as effective. If you're thinking people aren't getting increments, at the moment we have a lady, her platelet count's less than 5. We've been giving her 2 units a day and her platelet count is still less than 5. We did a post-platelet increment. It's just so you can see whether the platelets are staying, but they're just not surviving up for 24 hours. So you know that then they're getting destroyed rather than there's an antibody to the HLA or the platelet antigens on the surface of the platelets. So if you think there's a problem, then you do need to start looking at getting HLA typing done for a potential HLA match. And often the blood bank scientist is the person that recognises this, because you're forever giving the same person a platelet and you're looking at the count and it's not going anywhere. So it's a really good thing to check on and pass it on to your medical staff saying, this person's not really getting an increment. Because they can pass through many doctors, that can be overlooked, whereas as a scientist there's not that many people, so we can really keep a handle on all of these things. You can also get low counts in DIC and splenomegaly and immunisation, so the platelets can go into the spleen and not come out, and that way you need to somehow get them back into circulation. Now, all blood products go through a standard blood giving set. It really just takes out larger aggregates. In years gone by, there was a microaggregate filter. Hopefully they've been removed from every hospital in the country because they will filter out platelets. It used to be use them on a bag of platelets, you're giving a nice yellow bag of plasma and nothing else. And with all blood products, you don't add medications to the lines. None of them are validated. There's lots of additives in the packs, there's plasticizers, and you don't know a drug or product interaction. They haven't all been tested. So the stock standard answer for us is when someone asks, can I put this in with this drug? You say no. The only thing you can put in your line is saline. You can flush the lines with saline to get them out, get all the last little bit of residual platelets out. And you store them at room temperature. It's because it's a room temperature product, it's also most at risk of bacterial contamination. And they're only stored for 5 days. They are a high turnover product, and it's really hard for us in Tasmania to keep the stocks up and the supply. We get supplied every day from Victoria or New South Wales for the last few weeks, but I think we've gone back to Victoria now. So you've got to look ahead. You've got to have an idea of who's coming in or who's around. So, you do need information so that you can stock platelets. Unfortunately, we do waste a lot because you've just got to have them there just in case. So they've got 5 days from the date that they're collected, but their lifespan by the time we get them is either 1 to 3 days. 3 days will be very generous, and it makes it much easier for stock control. So if you're working in transfusion, wherever you end up in the country or around the world, it depends on where you are, your location near a blood bank, a collection centre, to see how quickly you can get supplied with products. If we run out of platelets in Hobart, we could wait to get some from Launceston if the blood service, Lifeblood, has no platelets in stock. Then we have to wait for a plane to arrive, and that can be quite hair-raising. So the practice that we have, there's types of platelets. There's an apheresis, which is a single donor product, and it's in an additive, so it's really got no anti-A or anti-B in it, but it is a single donor product, and because it's taken straight from a line, from an apheresis machine, there's not much interfering with it, so it's considered to be the best platelet product. So if you're having someone that isn't incrementing well, an apheresis product is something that you can try. A pooled platelet is also suspended in an additive, but it's for 4 donors. These the donations have been spun down, separated, put back together and spun down again. So you do, because there's a little bit more spinning, you can get a little bit more activation. The platelets are considered not as effective as an apheresis platelet. And there's paediatric platelets, which is really an apheresis platelet divided into 4 packs. So if you have a neonate, they only may need 5 or 6 mils out of a pack. So a large pack is sort of sad when you take a little bit out of it. So they do provide paediatric platelets. So, depending on what hospital you're in and what the what the clinical conditions are, you may want to choose a specific platelet. So for an apheresis platelet, as I said, it's single donor, so it reduces donor exposures. So we would choose that for babies and children. We try not to expose infants to donors. They've got a long way to go. Let's not expose them to anything. It carries minimal ABO antibodies, so you can cross a blood group barrier. So you can give an O, and A to an O, etc., so that you can use them in expiry date order. And they don't contain red cells, so there's no red cell contamination with apheresis platelets, which is a consideration if your patient's Rh negative and your platelet is Rh positive. You can quite comfortably give an apheresis platelet because you know that there's nothing in there for them to make an anti-D from. Okay. It costs about $900. Every blood product has a price attached to it. Tasmania and New South Wales have a blood budget that's moved down to the hospitals. Most other states haven't done that yet, but it probably will happen, and all the blood products have a price written on them. Just they thought it would change how people use them, but not really. So this is quite an expensive product. Pooled platelet concentrate, as I said before, it's a pool of 4 donors. Once again, that will increase donor exposures. Every time you get a unit of platelets, you get 4 donor exposures. So, you're also getting exposed to 4 different HLA types, so maybe there's an possible increase in HLA antibodies. You've got reduced ABO antibodies, as in the apheresis, so you can cross a blood barrier. So you can give the Bs to Os. We sit here on a stock of group O platelets. That's so that we don't throw them out. Right? If we know we've got an A bleeder coming in, we can order As, but usually we have Os because they're way more flexible, and we found that we discard a little. But they do have red cell contamination. Sometimes it's only, you see them up the top, there's a couple of little red cells in there, and other times you can see the bags are quite heavily laden with cells and they're quite orange. So if your patient's Rh negative and is a woman of childbearing years, you may have to give anti-D to make sure that they don't make an anti-D. So you've got to take all these things in consideration, and probably nobody else is going to remember to give them anti-D. So as the transfusion scientist, you'll need to be on the ball and suggest that you give them, or check whether it's they may not be having children in the future. And it's a relatively cheap cost of $280 for this product. So the paediatric platelets, the infusion is, depending on how big, if you've got a 24-week neonate to a 36-week neonate, they're about 16 mils. You would use apheresis to reduce the donor exposure. But in Hobart, we can't get paediatric platelets. They take a while to come in. And by the time we order them in, they arrive, the patients usually had a large bag anyway. So you do have to look at your crystal ball and see what they're going to use platelets for. And if they're not using them much, it's better to use the adult one. Okay, so there is a limited supply due to the 5-day expiry, and that's always a problem around Easter time and Christmas time. Donors don't come in, and there's always supply deficits then. So we use them in expiry date order. In a blood group, we will change blood groups so that we give them an expiry date order. And really for us, we get what we're given, so there's no choice. Whatever's on our shaker, sometimes we won't have apheresis, sometimes we'll only have pooled. Hopefully, if we get a child, we can order an apheresis platelet in and they can wait a little bit longer for the product. But if things are needed urgently, we've just got to give what we've got on the platelet shaker. So we really try and plan ahead with platelets. It's one of our most difficult products, and as you can see, there's lots of layers to what you need to consider. So if you've got a poor platelet increment, you need to work out the reason. Maybe they're being consumed. There could be a fever, or the patient may be immunised to platelet antibodies or HLA antibodies. So you need to go and get those checked, which is why we've just sent our lady off today to be checked. So I might have some answers soon. So how you can get around that sometimes is you can give a double dose of platelets to see if that sort of plugs up the holes, and then you can move on with the increment. You can give as fresh platelets as you can, the apheresis platelets, because that's considered the better product. And if all else fails, you have to get an HLA match platelet. So that's a little bit more difficult, and they have to find get your HLA type done. The blood service needs to find a donor, that needs to get collected, that needs to get on the plane and get here. So it does require a lot more organisation. but patients should do a lot better on them. Because it's a room temperature product, it has a lot more potential for bacterial contamination. So they're actually tested and they're issued, and they will continue doing the bacterial testing while will potentially transfuse the product. So you need to be really careful if you get a recall. There'll be a recall notice to say that this product is potentially contaminated. You need to put that up straight away. You need to find the patient. You need to make sure your medical staff know so that they could follow up with the patient. Now, if you've been given patient platelets in an outpatient area, then they could have gone home and be having a bacterial contamination at home, and that could be potentially lethal. Luckily, most of the patients that are on platelets are also on antibiotic, the chemotherapy patients. But you do need to follow it up. It's something that needs to be actioned immediately because it can have huge ramifications for patients. So the next product that we have is fresh frozen plasma, with something that we store at -30 in a freezer. It's got all of the proteins, all the clotting factors. It's got whatever's in your plasma at the time you donate. So whether you had for lunch or breakfast or whatever, it's all in that bag. And it's relatively cheap, as $180. And for pediatrics, you just cut that bag into 4, split it into 4 little bags. They're all nice and heat sealed, and that becomes your pediatric FFP. So you give FFP for control of bleeding and to prevent dilutional effects of massive transfusion. You can't just give red cells when people are bleeding a lot. You need to maintain the coagulation factors. You can get quite low on coagulation factors before you're in trouble. If you get below 15%, it's really no coming back. So it's something you need to keep up with all the time. Clottings are made in the liver, so in severe liver disease, you don't get, your clotting isn't going to be as good. And you get in factor deficiencies, there can be multiple factor deficiencies in DIC, coagulation problems, TTP, that you may need to give some FFP to assist in situations where they may be bleeding or going to surgery. But it's not a concentrate, so it's not particularly good. Sometimes we will get a request for a patient going to theatre and they want 1 bag of FFP. So we ask, 1 bag of FFP, well, what do you want to do? They say, oh, well, their INR is 1.3, so we want it to be a little bit lower. Well, the INR of a bag of FFP is probably 1.2 to 1.3. So 1 bag of plasma really won't assist at all. So you need to look at what the request for the FFP is for. And if they've got a factor deficiency, then you can give a product a specific factor to replace that, rather than just the general little bit of everything that you have in FFP. Sometimes I have used it in the past in nutrition, which is not ideal. There's plenty of other sources of albumin that you can use other than FFP. If you've got products like vitamin K and precipitate and prothrombin, then you can use those to help with a coagulopathy rather than FFP. So vitamin K is your warfarin reversal agent, really. So the dosage and administration depends on the clinical situation and laboratory testing. So it needs to be thawed, and you need to thaw it agitating so it thaws quickly, 30 to 37 degrees. It is a protein. If you thaw it at a high temperature, you will cook it like an egg. So you want to be really careful with your temperatures, and it needs to be used immediately. As soon as it's thawed, that's when it's got its maximum factors available. But if it can be kept for 5 days, if you're wanting for factors, the best way to have it is straight away. So it needs to be ABO compatible and not identical. There's no red cell contamination, so you don't need to worry about the RH of the product. So if you're group O, we'll give you O plasma, but you could have A and B as well because you're not getting any extra. standard givings there, 10 mils per minute and no medications, just like the other, no medications are added. So this is just an example of a patient that we came in, can see born in 2002, relatively young, has a HB of 83, fairly lowish across the board, with a prolonged INR, and that's kind of unusual in a young person. So you would go back and have a look at previous results. On the basis of these ones in July, though, the medical staff ordered some FFP. So when you go back and look in May, which is probably pre-operatively, the HB was significantly higher and the platelets were significantly higher. So if you ask the question, where has their HB gone? It wasn't iron deficiency. There'd been no active bleeding. So there'd be no reason to think that those results, unfortunately, there wasn't a coag done. So a repeat was asked for. Because they're rather unusual results in a youngster, a repeat was requested, and you can see that the INR is 1.2, so we would have been given FFP to a patient that didn't need it. Okay, so it's really important when you get a result that looks slightly odd that you do think about it and ask some questions about it, because the last thing that we want to do is give somebody a blood product that they don't need. So it's always good to ask a repeat, especially if there's no reason for the results to be that way. So always put your thinking cap on when you get results and look at each one critically. So cryoprecipitate, if you have a unit of red cell, a unit of FFP, and you thaw it slowly, you get a little precipitate down the bottom, which is this cryoprecipitate. It's about 30 mils, so you now get a bag of plasma that's got no cryoprecipitate, so it's cryodepleted plasma, and you get this little bag of cryo. And this is really our fibrinogen concentrate. There is a localized fibrinogen concentrate out on the market, but it's not for general use yet, so it would be nice. I mean, it will be coming, but it hasn't arrived yet. So fibrinogen comes from our cryoprecipitate, and it's really the only thing we use it for. It does have a little bit of von Willebrand's factor in it, so it could be used for von Willebrand's disease, but there is a specific product by a state that you can use for that. But in massive transfusions, it's also something that you need to keep up. You need to keep your fibrinogen levels up. So if your fibrinogen is low, you can give 10 bags of cryo that's 300 mils, and you get a lot more cryo, a lot more fibrinogen than giving FFP. So you do need to check on blood volumes, and always check a coagulation screen and know what the fibrinogen is, because you can't look at a patient and know what their fibrinogen is. You can usually have a look and check to see that their HB is not going too well, or the Uzi, they may need platelets, but you can't tell what their fibrinogen level is. So it's important to do either monitor by coagulation or by a thromboelastogram. So usually about 4 units per 10 kilograms of body weight. You've got to remember, though, when you're doing coagulation testing, it's quite removed from when the sample was collected. So you're looking at 45 minutes minimum from when the sample's collected to when you get a result, by the time you enter it, spin it down, pop it on an analyzer. So if someone's actively bleeding, you then have to consider that they need to have their fibrinogen raised back to where it would have been, and it's probably dropped lower in that interim. That's why you just need to keep them going and have good medical staff liaison with the bleeding area. As I said, you can't tell, so you've got to know what your laboratory testing indicate. It's the cryodepleted plasma that's made by having that cryo taken off, and we use that for it's similar to FFP without, of course, it lacks the fibrinogen and a few of the von Willebrand factor and factor 8. So you can use it, and we would use it for TTP and plasma exchange, and it can be used for Wharton reversal because it's got a little bit of everything, and incredibly similar bags. So at one stage, the blood service had delivered us cryo-depleted FFP instead of straight FFP, and my staff didn't notice, and it took us until I went to the freezer and found the thing. So all it is a little letter on the pack. So they're very similar, so you need to be attentive in whatever you do in transfusion. So I thought it might be time for a break and a stretch and a drink. And was there anything I need to answer, Jane?
Sorry, I had my microphone off. We haven't had any questions from any students. Any questions?
Excellent.
Anybody got
All
any
right,
questions? No. So we'll have a 5-minute break, Gina. So I'll be back at, say, 12:36.
Excellent. All right, I'll go grab some water.
Good idea. See you in 5 minutes.
Okay, how are we going? I see you're all still there.
Yes,
It's hard
yes,
to
you're
know,
right
isn't it?
on time. So if you have looked down on your right hand side, oh, you may not see it with presenting, you probably don't, but we
No.
still have a number of people still here hanging on your every word, Gina.
That's all I can see is my talk. So I can ask questions or see the happy faces or see who's falling asleep.
Yes, so I've got a few students here saying, yes, we are here. So they are still here and hanging
Excellent.
on your every word, Gina.
I thought it's just you and
Okay.
I talking, Jane. Okay, so as I guess you kind of twig now that, lots of people think that the transfusion is all to do with red cells, but lots of the other products, the platelets and FFP and cryo, they take up a large amount of our time. And it's really important that even you're working in blood transfusion, you actually know all about your hematology and your coagulation, because they all fit together and you can make some very informed decisions from a good depth of knowledge. So these are our red cells. They contain 300 mils. They do contain a little bit of platelets and white cell contamination, but they are leukodepleted. And recently we've moved from a 7-digit donation number to a 13-digit donation number, which just makes it's an international standard. It's been coming since I started in 1992. I thought we were getting ISBT numbers, and we really only got them last year. So it's taken a while. Some things don't move fast in blood transfusion, but we get there eventually. So red cell concentrates or packed cells, really only one reason to use them is oxygen to the tissues. That is blood's main role, is to get oxygen to the tissues. So anybody that has symptomatic deficiencies in oxygen carrying capacity, you need to give red cells. And they can be ABO compatible, not identical. So you can give O neg to O pos, you can give O to group A and AB, so you make sure that you match from a back group. But you don't give red cells when the patient's anemic and they're not symptomatic, and it can be corrected by giving iron or vitamin B12 or folic acid. So you don't want to give a person a blood product if they don't need it. Right? It's really important, just to give some iron. It won't happen quickly, but it will certainly improve their health straight away. One of my biggest bugbears is giving young women who've just had babies blood for a low HB, so they have energy when they get home. I don't know why you want to expose a young woman with a blood product when they don't need it. Very important to give them iron and monitor iron levels throughout pregnancy, so that when they do deliver, they're not going to be iron deficient and can tolerate a little bit of blood loss. So you don't give red cells unless they're ABO compatible, and you need to do compatibility testing. So it's the FFP and the platelets, we can just hand them out on groups, but every time they need some blood, you need to make sure that it's compatible. So you need to check that there's no antibodies. Now, in emergency situations, you may not get time to do the compatibility testing, but that becomes a medical officer's decision, knowing all the risks and all the potential there for antibodies. So there are quite a few risks associated with red cells. It could be hemolytic transfusion reactions. That can be from maybe they didn't collect the sample from the right person. Maybe they didn't give the blood back to the right person. Maybe there was a laboratory error, which is unheard of. Not really, but it can happen. So they're usually connected with incorrect blood. Okay, so for us in the laboratory, how we stop that is that we have a collector signature, we have a witness signature, and everything needs to match. Because everywhere else in haematology, or mostly pathology, you're giving back a result. And the doctors can say, oh, well, no, HB of 45, no, the patient looks fine. That's right. But they can't look at a patient and say, oh, no, you're B pos, not A pos, when they gave the blood. So best things we can do there is to make sure that the sample is collected from the correct patient. So that's why we have collectors signatures, and they have to sign the declaration as well as a witness as well, so that it's correct. And then it comes down to the nurse staff at the other end to check that that's the right patient that it's going to. So there's lots of checks and balances, but they are human systems, and when you get human systems in there, they can potentially go wrong. But everyone has to check as much as they can. You can get transmission of infectious disease. You can get malaria from blood products. You certainly got HIV from blood products. So there is always the potential for disease transmission. The blood supply is incredibly safe, though. It's very little disease transmission, but I think it's still good to remember the lessons learned in the early 80s when people stopped transfusing blood unless it was absolutely necessary because of the potential of HIV in the blood supply. You know, that potential is still there, maybe with a future virus, but it's also good. Here they go. They said they wouldn't talk much. So you want to make sure that you don't transmit. You want to make sure that the patient actually needs the blood in case there's any disease transmission. There's lots of antigens on the red surface of the red cells, so you can make antibodies to anything that you don't carry on your own red cells. So you can get alloimmunization of the recipient. You can get febrile reactions from white cells. You can get bacterial contamination. Anytime you're giving a needle, you can get air embolisms. You can get iron overload on patients that are repeatedly transfused. Suddenly they're iron overloaded, and that doesn't do any of their organs any good. So at some stage you're going to need to reduce their unload. So that's what's really important, to not give too much blood. Just give enough so that they're over their symptoms, so that you don't iron overload. Hypothermia and citrate toxicity have become important when you're transfusing a lot of blood at once. In a trauma situation, hopefully they're giving those products warm, because the blood will be at 4 degrees and you can change the temperature of the patient. If you change the temperature of the patient by giving lots of 4-degree blood, you've totally changed how their coagulation works. So remember, in the laboratory we're testing coagulation at 37 degrees. But that's not what temperature the patient's at. So we're getting a best case scenario, and we're saying, oh no, they look okay, but if the patient's hypothermic, then they're not clotting like we expect them to. So in situations like that, you really have to take note of what the medical staff at the coalface are ordering and doing, so that you can give them the right product. It's really hard in the lab, scientists and the doctors, to say, oh no, they look all right up here. Well, no, your patient's bleeding down there, so you just have to give what you want. What I also should say is, when you're issuing a blood product, you're responsible for looking at it before you issue it to make sure that it's okay. So bacterial contamination you can pick up by visual inspection of the bags. So for platelets example, they may be little white clumps, aggregations in the bag, and a red cell will get quite dark. So it would go black if it's bacterial contaminated. Cells themselves come in lots of different colours. So you get the very cherry red packs, which are smokers. I hope none of you are smokers. They look pretty pretty, but they're carbon monoxide, not carrying the right sort of oxygen. And I don't want a smoker's blood. Yeah. The darker ones, nice arterial dark red blood, but when it goes to black, there is a potential for bacterial contamination. So I usually tell my staff, FFP also comes in a myriad of colours as well. You know, if they're fatty, they'll be opaque. Women on oral contraceptives, often they've got a greenish tinge to them. But I tell my staff that if you don't like the look of the pack, don't issue it. If you think there's a potential there for it to be a problem, then don't issue it. Find another pack to give. And we have done that on the odd occasion and had growing. They have cultured them and they did grow something. So it's a really good pickup by the staff. So it's also something that a scientist has to do before they use your product, is make sure that it's actually okay. One of the biggest issues is clerical error. When I started in transfusion, before you're all born, possibly your parents, God no. Everything was manual. Write down everything. You had to note donor numbers on a piece of paper, another piece of paper here. Now, with computers, you pretty much get rid of most clerical errors, but you still need to pay attention to what you're doing and not assume the computers will do things. So, you know, nowadays we enter into a system, the results go up to the analyzer, the test goes to the analyzer, and the results come back into the computer. So there's no human interaction anymore, and the analyzers do all of our work for us. So the risk of clerical errors are minor, and your computer systems now have, you know, it doesn't let us give a group AB to an O person. There's all the rules in there. So everything that used to be scary about blood transfusion is pretty much taken away by analyzers and computer systems. So it's almost foolproof. But computers aren't perfect. So you need to know what you're doing in case your computer system's down or your analyzers are down. And then there's lots of potential there for clerical error. And we had a patient called Barry in theatre. The nurse said they said to go and get some blood. She went to the fridge and got blood for Barry. Then they hung it up and they realised that it was, yep, it was Barry, but it wasn't the same surname. So Barry Group O got Barry Group B's blood, which is not ideal. So when you're checking, you need to check everything, not just what you think. You know, blood for Barry. I know they were busy, and that's the problem. Oh, yeah, we were really busy, and you know that's when you need to be even more careful because that's when problems can happen. Immunomodulation, transfusion-related immunomodulation, every time you get a unit of blood, you downregulate somebody's immune system. So it's not a good idea to give blood if they don't need it. Okay, so 1 unit will downregulate it, 2 will downregulate it even more. So it's very important that it is only given when required. Blood shortages, in Tasmania we've had few blood shortages, primarily because we are now, we have to wait for planes to arrive. We even had a charter plane come in a couple of weeks ago because we couldn't wait for products. So, and depending where you are around the country, you know, if you're working in Western Australia, you've got long distances to get blood. So if you have a major trauma, you need things replaced quickly. So you need to think ahead with your blood. When you're ordering blood, how much do I need? What groups do I need? This patient's bleeding, I better get some more in now, because the earlier you can tell lifeblood, blood service, the lifeblood that they need more, then they can start getting it ready to get to you, because you're going to have some delays. Even when I worked at the Alfred in Melbourne, I think we were maybe 5k away from the collection centre, but at peak time it could take an hour through traffic. So everywhere where you work has a slightly different demographic of how long it's going to take and where you call from, where you get things. So you do need to somehow manage blood shortages. You may have to pass a message on through the hierarchy of the hospital and stop elective surgery in case there's not enough to go around. So also transfusion behaviour, that's more related to the medical staff. You could go to Dr. A and he doesn't give you any blood for your hip surgery, yet Dr. B almost transfuses everybody who has hip surgery.
Excuse me, Gina, if I can put in, I think it was to do when you were talking about blood shortage. Kiani has asked, do you have any sort of a priority when you do have a blood shortage, you know, as like ambulances do, or, you know, triage does? Do you have any sort of priority there?
It's a little bit difficult. Certainly elective surgery is what's bumped off the list first, but you do need good notification of that. So your chemotherapy patients still have to go. It's probably where you would have given 2, just give 1, because you've always got to have some blood for the next trauma. And we have run out of blood entirely on one trauma before, and we were fortunate or not fortunate that the patient died and we could get restocked. and we didn't have much other blood after that. But yes, there is a whole contingency plan run by the National Blood Authority on blood shortages around Australia, and you know, a whole lot of action plans between red, yellow and green lights as to what you need to do. I'm not sure, we probably get to it later, but the National Blood Authority also knows how much blood every day we enter our stock into the system, so that everybody knows, well, they know where all the blood is around the country. So we're very lucky here. We can just probe up Path and ask if they've got some blood, or Launceston can send us some blood, and which they all did when we had this bleeding going on. But the National Blood Authority can also move blood around the state, around the country, because they know where everything is. So it's not that you have a priority, because if someone's bleeding to death, you can't prioritise one over the other. But there's lots of things that we can do in the medical thing to make it, you know, use as much. But elective surgery certainly goes first. They don't use a lot, but you know, there has to be some traffic light system. Hope that answered your question. This is a fairly old study, but it's still one of the best at proving that blood is not the life-saving product everybody considers it. So it was a very large study on ICU patients, so it sort of evened out every issue between, you know, sick patients. Oh, well, the sicker patients were getting more blood and the less ones. So ICU and hospital length stay increased, and deaths increased the more units of blood that they had. So the non-transfused group patients had a much lower mortality rate than the transfused group. And this study pretty much overnight changed how intensive care units around the world, and certainly here, used blood. So before, people would have a trigger of 100, everyone had to have 100. We were trying to desperately get away from triggers and only go when people were symptomatic, which is hard in a intensive care patient. So they really pretty much dropped it down to 70. So they sit in ICU with an HB about 70. If it goes more than that, they will top them up. And so, you know, they're trying to give minimal blood to the patients. Often hard to see symptomatic because they're not awake and alert at the time. Okay. So red cells should raise an average adult HB by 1 to 2 grams, but that is entirely dependent on how heavy they are. Sorry, just trying to check the phone at the same time, see how long I'm blabbering on for. So if you've got a 50 kilogram woman, she'll get a much higher increment than a 150 kilogram woman. Okay, so it does make a difference weight-wise, so a small person certainly doesn't need much blood, or doesn't need, will get better increment. So a standard blood giving set, it has a little filter in it to filter out all the little aggregates that can form over time if you've got a 45-day-old bag that you're transfusing, and it can be warmed if clinically indicated. We have quite a few patients that just have cold agglutinin disease, so their blood needs to be warmed, and we also do that on patients who have Lewis's and anti-Ms, that it's not clinically significant, 37 degrees, so we would give them warm. So you need to make sure that they use blood warmers and that they're available. Blood shouldn't be up for any more than 4 hours. If you've got a particularly fragile, frail person who needs a very slow rate of transfusion and you haven't got all the unit through in 4 hours, take it down and put up another unit, because it's been out, it's now getting at room temperature, and that's when the potential of bacterial contamination can increase. So 4 hours is ample, and that's pretty much for all blood products. They need to be done in 4 hours. Most blood transfusions are done in 45 minutes. Okay, so 4 hours is fairly odd. But you'll get questions, oh, I've had this up, you know, take another one up. And with all blood products, no medications and things added to the lines. So they're filtered to remove the white cells, and that was a great big improvement in the blood supply over the last 20 years, that there's no limited white cells, that they're in the pack, so that really reduced transfusion reactions. So the febrile transfusion reactions, which are usually due to cytokine release of white cells, have really decreased. You hardly see them, very, very rare. CMV negative blood, it does render the blood CMV negative by removing the white cells, but they also do provide CMV negative blood on the blood bags. Okay, there's really only one indication for CMV negative blood, and that's of women who are pregnant. Okay, so you don't want to transmit CMV across the placenta, so you always make sure that if your patient's pregnant and needs blood, a very small group of patients get transfused while they're pregnant, you do need to give CMV negative blood. And you can get HLA immunisation as well. So like the platelets, we can irradiate them to prevent graft versus host disease, immunosuppressed patients. We only keep a small stock of irradiated blood. That's because it's got a shortened expiry date on it, and so we keep it going. Now, if a patient that needs irradiated blood bleeds a lot, there may be a situation where irradiation, we can't support them with irradiated blood anymore, and that's a conversation that you need to have with your medical staff so that they can pass it on. Right, and you'll need to do document everything so that you have got it covered. But if it comes down to no bleeding to death or potential, then someone needs to make that decision for you. So this is basically the standard giving set. It should be changed every 4 units of blood, and you use it for all blood products. Probably they will change the 4 units eventually, but it's been a standard since day dot, I think. It's probably the time for an update. So this is just an example of a patient. So the patient, it was collected at 10:40. We got the sample at 11:21, and there was a result put out at 11:40. So it's an hour to get an FB result. The HB was 42. The white cell count 1.4, platelets 36. So it's fairly unusual results. So in those situations, we would ask for a recollect just to make sure that it's correct. As you can see, it took quite a substantial amount of time for the recollect to come. So at 2 o'clock, the HB is now 37 and the platelet count's getting lower because by now they're taking out lots of samples for things. Okay, so from 10 o'clock to 3 o'clock, there's nothing going on, and now at almost 4 o'clock, we get a sample for a group and hold. So this poor kid sat in the emergency department for quite some hours, and at 5 o'clock finally get some blood and some platelets. And they've sat around for many hours, and we probably could have addressed that back here. So if you want to recollect, it's really good to keep reminding them to get the sample, get the sample, get the sample, so that you can action it rather than have these huge delays, because that's really not the best treatment of the patients. So after the red cells, many other plasma-derived blood products, a lot of them are being replaced with recombinant products, which is excellent. The ones we deal with here are in black. We look after all of those in our laboratory and the pharmacy. There's a strange thing between pharmacy, which ones are ours and which ones are theirs. So, you need to know how all of the products are used so that you know when they ask for a product that's incorrect. So albumin comes in 500 mils and 50 mils for pediatrics, and the albumin X20 is 110 mils for pediatrics. And they are human blood products. They pretty much look fluorescent green, so people can often consider that they're not blood products because they don't look like blood products. They come in a bottle and they're so much removed. They're pretty much the colour of the slides, the bottles. But they've also been heat inactivated, and they've never transmitted any disease. If this is your volume, your albumin can use volume, and your albumin X20 you'll be using for edema and things like that. As I said, albumin X4, plasma replacement, shock, when there's fluid loss, You often use it in plasmapheresis in combination plus or minus FFP, depending on their blood products, what their coagulation's doing. You can give it shock until blood is available, and you can use saline as well as albumin X4. There was a study many years ago done by CSL comparing albumin X4 using saline, and they pretty much proved that they work the same. I'm unsure why people still use albumin X over saline when one's a blood product. Relatively cheap, $67 for the big bottle and $15 for the little. So albumin X20, we use it mostly in liver disease patients, okay, to get rid of the edema, get the fluid out of them. And often the ICU patients, depending on how long they've gone, they do get low protein states and need albumin replacement.
Gina, can I ask?
Sure.
I remember hearing a few years ago now about there was a big hoo-ha about shortages of albumin in Australia and the fact that we were importing albumin from internationally. Is that still going on, or are our stocks all in Australia?
No, that's the albumin's been pretty much Australian for a long time now. I can't remember the last time it was imported. Intravenous immunoglobulin is certainly imported, but that's most of the time. We're pretty much self-sufficient, which is excellent.
Very good, thank you.
And if there is a choice, the Australian product's usually, a little bit more expensive than the overseas product, but you would consider it better. So you don't use albumin for long-term malabsorption problems, and you don't use it for nutrition. So Biostate used to be the factor VIII concentrate, and Biostate in its previous form, which was HF, anti-haemophiliac factor, is a product that unfortunately in the 80s was contaminated with HIV, and we lost a generation of haemophiliacs. Biostate is still got a factor VIII concentrate, but there's now recombinant products. So Biostate is really our von Willebrand's factor concentrate these days. Dosage and administration depends on what the patients are having done. So I'm sorry, I'm sure you all know what von Willebrand is, so I'll just skip through that, but you do need to replace the factors if your levels are low or that they don't work properly. So there's a whole raft of recombinant factors now, and they usually have some they've all got some really kitsch names for Advate and Zinthar. So Advate says 8 in it, and then Zinthar is XN for males, for the nth, whatever. Benefix was a factor IX concentrate. It's now just been replaced by Alprolix, and of course it's got the IX on the end so that it's 9. And there's a whole lot of factor VIII products that are coming out so that the haemophiliacs now can use them at home, and they're longer lasting products than the standard blood products. So there's big movements in the recombinant products or the monoclonal antibody products, and that's making some really big improvements for the haemophiliacs. So there's other products. Factor VIII inhibitor bypass product is FIBA, which is pretty much, it's like it says, factor VIII inhibitor bypass. So if you've got inhibitors to factor VIII, you can use your FIBA or you could use your Novo7. There's also a brand new monoclonal antibody out on the market that our haemophilia with inhibitors on, and he's made, he's so much better on the brand new product. So a haemophilia centre certainly needs to be involved in all those decisions. And then the NOACs, you've got to do your dabigatran reversal and Praxbind, and there's a whole lots of things for your Roxvan. There's new products coming out, and you need to know how to reverse them. So Novo7 is still popular in use in inhibitors with factor VIII, but it has been pretty much superseded by, I can't even think of the name, a juice that I can't even say it, so I won't try. So really now its only use in Australia is for bleeding and surgery, uncontrolled bleeding and surgery. The reason for that is that to get to coagulation, all you need is fibrinogen and platelets. Okay, you can give recombinant factor 8, will give a thrombin burst and activate your platelets, which will then get some more factor 7 going, and it feeds back, and then will give you a nice clot. But Novo 7 cannot work unless you've got enough fibrinogen and enough platelets. So we've usually found by the time someone's bleeding in theatre and you replace their fibrinogen and platelets, they've stopped bleeding anyway, and then you give the Novo 7. So it's really hard to tell which ones, whether it's the platelets and FFP that have worked or cryoprecipitate that have worked, or whether it's the Novo 7. But it's still used as a sort of a last ditch to get people through to stop them bleeding. Thrombin is our it's a television station one. No, you don't have see, you can't do that at SBS and ABC anymore. 2, 7, 9 and 10 year factors, clotting factors in your liver. So it will replace those. So it is the product that you would use for warfarin reversal and also for your NOAC reversal, apixaban and rivaroxaban. And there's still more of those coming out onto the market too. So they may eventually have specific NOAC reversals, but at the moment the Prothrombin X is what you give if their levels are out. It's a freeze-dry product, and since there hasn't been any disease transmission, so you can use it in your warfarin by intrinsic pathway. You've got your rivaroxaban and your dabigatran at the bottom, and your FFP, and FFP really won't do anything for those, so you need to get your doctors involved, and you need to suggest that they could use Prothrombin X. So you do get bleeding risks with warfarin if their INRs go above 4. You need to know, that they're older, they're going to have a higher bleeding risk, they may have strokes or liver dysfunction, have a few too many drinks during COVID or on drugs. And some people, that will change how the warfarin works. And poor compliance. Sometimes people forget what colour tablets at time they've had, or may just take the wrong tablets at the wrong time. Oftentimes Christmas time, when we're all sort of eating and drinking a little bit more, we often see quite a few increases in INRs. So this is just a case scenario. It's a patient that comes in with an INR of 6. They're on warfarin therapy for an AVR, but they're not actively bleeding. So you have to then consider why they got a high INR. Now you're looking into this because someone's asked you for some FFP. They've asked you for 1 or 2 units of FFP, and you've looked them up and you've gone, oh, do they really need this? I'll go and check through. So yes, they're on warfarin, or they could have vitamin K deficient, or they could be liver dysfunction if they're not on warfarin. So you need to ask some more questions, or you go and find your medical staff. But it's always good that you have a good idea yourself as well. But definitely get your medical staff in. Are they bleeding? So if the patients are bleeding, then there's a different action to if they're not bleeding. Like if they're not bleeding, you can just wait, and that will probably, the INR will decrease. If they're bleeding, you need to assess the bleeding risk and probably reverse it straight away. So when you're reversing it, do you want to reverse it back to normal, or do you want to reverse it just a little bit? Because people that have valves, you don't want to get it back to normal, because then they're at a clotting risk. So you've got to work out a nice balance between what you want to do. So if they're bleeding, you need to reverse it with your vitamin K or Prothrombin X, and definitely talk to a haematologist to get the right doses. If they're not bleeding, you can give vitamin K. It will reverse them quite quickly. Okay, and if they're going to surgery, maybe you could delay it till the next day so that they aren't at a bleeding risk. So there are things to do. You just don't want to give FFP, and you don't need to give FFP. You would be giving Prothrombin X for a warfarin reversal anyway. And people ask for FFP for warfarin reversal, and they'll also ask for they're on heparin And I'm sure you know that heparin can't be reversed by FFP at all. So thrombotrol is another product that we have. It's the antithrombin 3 concentrate. If you've got an AT3 deficiency, you will need it if you're going for surgical intervention. You can give it prophylactically to prevent thrombosis in people with pulmonary embolism and pregnancy. You may need to you may have an acquired deficiency, and SYN kind of. At the moment, we're using it quite a lot in heparin-resistant patients on cardiac bypass. So they're not getting the results that they need, so they need some AT3 to get the APGT up. And usually there's a haematology consult. People will ask you for products you've never heard of, and you're going to have to find out where you get them from. They all come from the lifeblood, so you can contact them. So Intragam is also a product that we use quite a lot of. It is this is the one where we import quite a significant amount. We aren't self-sufficient in IVIG. We do have, it's very much governed by the National Blood Authority. You have to order from their guidelines, and in the laboratory we only issue via the computer on the MBA, and we can only issue for what their use is. So we don't have to get involved in any of the indications. That's all run by Lifeblood, and then we issue as per what we're told. Just a little bit on anti-D, because I think it's one of my favourite and most fascinating issues, is that, you know, if you're Rh negative and your partner is Rh positive and you know that they're an R1, then every baby is going to be positive. So for us, if you're an antenatal patient and you're negative, if you know your partner's negative, then you don't need any anti-D prophylaxis. If you know what your partner's type is, you know, if they're an R1 little r, then you've got potential of having positive, a negative baby, even though it does say positive there, that's negative. So, you know, your little Rh positive baby's tucked in there, and it's fairly kept from your circulation, but at delivery you can get some fetal cells that get in the maternal circulation, and then you can possibly make some Rh antibodies to these red cells. And Rh antibodies will be sitting in there in your circulation, and the next time that there's an Rh positive baby, they can cross the placenta and do some big damage to the babies. So you can only be immunised either via transfusion or pregnancy. Usually the first pregnancy is okay unless there's been an event during the pregnancy, or it can be stimulated at delivery. So hemolytic disease of the newborn is in Tasmania, we don't deal with those. They would go to Victoria for intrauterine transfusions, and if they're delivered, they will probably need transfusions as well. Anti-D, the whole anti-D story is fascinating, so I've probably gone over it a bit more, but it was just injected people with anti-D and they didn't make them. So it was very, very kind of the prisoners to do it. It's nothing that you wouldn't get through ethics now, but when back in the 50s, that's how it was done, and that's how the 3-day hold came into effect, because they gave people anti-D and they could only access them. They were only allowed to the prison every 3 days to test. So that's where our 72-hour rule came from. It's very flexible science, but it worked, and anti-D was a great addition in the 60s, and then in the late, can't quite remember now, when prophylaxis. So even though there was anti-D, there was still a small amount of people that were getting immunised. So they did anti-D prophylaxis, November 2002. So at 28 weeks and 34 weeks, you get anti-D. So if there's some small bleeds at the end of the pregnancy, they're mopped up by this anti-D, so that they're not going to make their own. The woman is only at risk if her baby's Rh positive. There is testing now. It's not really available for the laboratories, that you can test the Rh of the baby from the maternal circulation. you can get that done. The lifeblood reference laboratories will do that for you. Maybe it will become a routine test one day. So you don't give people a blood product. But this is it's always been a safe blood product, even through the 80s, to transmit anything. But if the father is Rh negative, then the baby's not at risk. So the trouble with laboratory testing is that we cannot tell prophylactic anti-D differently from immune anti-D. So we've got no way of knowing at all. It'd be nice if there was a test. So we have to then, when you get your results and you've got positive, you have to work out whether the baby, make sure that there's been a negative antibody screen and proof of prophylaxis being given. So before you give prophylaxis, you need to have a negative antibody screen. So we're quite particular in making sure that that sample is within a month of the 28-week administration, because we've got no other opportunity until the woman delivers to find out whether she's made her own or not. So when you're looking at prophylactic anti-D in the maternal circulation, it usually sits at about a score of an 8 or a 2, depending on what scale you use. Okay, but anti-D of a score of 10 or 12 is never prophylaxis anti-D. You've got to be really suspicious of immune anti-D. So when you're out in the real world and you're testing and you're getting prophylactic anti-D, you've got to really make sure that it's prophylactic or immune, because the immune anti-D has huge ramifications for the fetus. So you need to monitor them differently. So just don't, oh yes, I looked up, yeah, she had anti-D 6 weeks ago and it's score 10, terrific. It won't be a score 10 if it was given 6 weeks ago or 12 weeks ago. So you need to look. The only possible indication, I would think, that if a score of 10 on a prophylactic anti-D would be on a rather petite person who'd had 2 lots of anti-D very close together. So there could be some reasons, but you need to ask and investigate.
Sorry, Dean, if I can
yep.
Interrupt. When you're talking about the score, are you talking about a titer, or are you talking about the strength of agglutination?
Yeah, just the strength of agglutination. Okay, so our analyzer works on a 0 to 4 scale. Our scientists work on a 0 to 12 scale. They're resisting the temptation to go to 0 to 4, but it really doesn't matter as long as everybody's consistent. You can titer. Prophylactic anti-Ds usually don't go past 8 or 4. They're very low levels, and that's also how you can monitor them. You can, if you get a sample and you do a titer today and it's 8, and you ask in another 4 weeks for a repeat sample and it's now 4, you can pretty much guarantee that's a prophylactic anti-D fading out. And if it's going the same or higher, then you've got an immune anti-D. So monitoring via a titer is useful if you're not sure whether it's prophylaxis or not. So how we're monitoring, is a Kleihar test. Beautiful. Wish they all look like this, a lovely clear background in your fetal cells, because they're nice pink, they stain pink. This is an example of a patient who had an HB on the cord and it was 58. So a baby's HBs usually sit around 100, so HB 58 is incredibly low. So investigated whether there was any antibody that had been missed, because sometimes people don't get monitored through pregnancy. There was no maternal antibody, so that wasn't a case for it. Kleihar was performed and it was very positive. Most people these days will send them on to flow cytometry, and there was an 85.2 mil fetal maternal hemorrhage. So this is a negative mother with a positive baby. So 85 mils requires 15 vials of anti-D. That's a lot. It is an intramuscular injection, but there is an intravenous option that you can give that the blood service, Lifeblood, I never get used to the change of name. They stock it. We don't stock it in the hospital, but we can get the intravenous product if we need to. So that's a better option when you're having to give large vials of lots of anti-D. So you check serially as to how the hemorrhage is going, whether the fetal cells are being cleared. So this is, you can see at birth, this is the fetal cells. And then after 15 vials of anti-D at day 7, you can pretty much see that all those fetal cells have been cleared. So it is a very effective product. You get it in 2 types. There's 250 IU for use in the first trimester indications and 625, and that's used for delivery of a positive baby. Anytime that there's a fetal bleed, and use it, that's the 625 use prophylaxis at 28 and 34 weeks. It will mop up 6 mils of fetal cells. Anything over that, you then do 1 international unit per mil of bleed. And the Rofalac is the intravenous product, which you can order. You probably wouldn't stock it because there's not a lot of fetal and maternal hemorrhages, but it's something that you can call on straight away. And this man was the world record holder. He donated, was in every vial of anti-D from inception to a few years ago, and he got too old to donate. So this is why it's a product that never transmitted anything, because it was long-term dedicated donors that had their antibodies stimulated all the time. So we need a quick break, or we power on through?
I wouldn't mind a quick break just to go and get a glass of water.
Yep,
so,
perfect.
So again, another 5 minutes, everybody. So if we get back here at 1:28, please. Thank you,
Very
Jeannie.
precise. 1:28. Oh, set my clock.
Computer clock. Okay, are we all back?
Yes, I'm here.
Yep, and we've still got 21 people here, so
Oh, they've just left
everybody.
their computers on. They're not actually there. Oh, okay. So we can power home now.
Mhm.
Jane, if they've done massive transfusion lectures already, I keep forgetting to look at the.
So we're having we've learned about massive transfusion and critical bleeding as part of not unusual, but not normal, special circumstances of compatibility testing. But Chantel G. Mackerel from the LGH is going to present a tutorial on critical bleeding and massive transfusion on Thursday. So you're a bit of an introduction for her.
All right. Well, we'll see. um, uh, I know RHH and LGH don't agree on what transfusion, massive transfusion, but see, that'd be interesting since as they would train Chantel which way she goes. I'll have to check it out. So for a massive transfusion is really considered greater than 10 units of blood in 24 hours. Okay, that's kind of a lot of blood. They've certainly replaced a blood volume. So you do need, and if you've given a lot of colloid or crystalloid, which is like a albumin replacement bottles, you do need to start giving some red cells because you're diluting people out too much. So you want to have oxygen carrying capacity because that they need to perfuse your organs and your brain, which is an organ anyway. If time's available, then they should be fully cross-matched. But you can give group O blood. O negative is always been considered emergency blood. It is pretty much overused. You do have lots of shortages of O negative blood. It's probably what you hear the Lifeblood doing advertisements about. It's because it is used as emergency blood. So we will use O positive in this hospital for men and elderly women. Most people are Rh positive, so we're not at a good risk. And the worst thing we can do is immunise people. And if it's a man or an elderly woman, they're not childbearing age, so it's not considered a risk. So we're trying to conserve our O negative blood for people who are actually O negative. If we have an obstetric bleed, then we need to save it for them. So group O, either positive or negative, is what you would use if you cannot get cross-matching done in time. So the effects of a massive transfusion, you get a coagulopathy if you give too many red cells and not enough plasma and fibrinogen. I still remember many years ago we had a patient bleeding in theatre and they used red cells and red cells and red cells and we couldn't get them to use any FFP. So one day we gave 10 red cells, had a huge coagulopathy. The next day we gave 10 FFP and they were pretty much dead by the next day. So you can't catch up. You need to keep it going at the same time. You get microvascular bleeding, you get acidosis and poor tissue perfusion. Mentioned earlier about hypothermia if you change your core temperature, and you get acidosis because you've given a lot of product. So you get all electrolyte imbalances because you're giving all the potassiums and the citrates from the blood bags. So sometimes people forget that they happen with a massive transfusion, and they are what you're infusing in via the blood bags. So you do need to, the medical staff need to balance all that out. And we're looking at it from a laboratory point of view. And as I mentioned earlier, if your patient's been in a car accident and they've probably changed, in wintertime, they've changed their core temperature, and our coag testings are done at 37 degrees. So we're not comparing apples with apples. But you certainly get a coagulopathy if you give a lot of blood. You can get DIC if there's tissue injury, certain brain injuries. You get a lot of DIC because it will activate your clotting. So your coagulation is a really poor correlation sometimes to what's going on with your patients. So generally, as a rule of thumb, you will always give platelets if they're getting below 50. You'll give an INR, keep it under 1.5, and you want your fibrinogen greater than 1. So when they start getting below those levels, you need to action them quickly to get products. We're really lucky here, and probably every laboratory I've worked in had really good medical staff to help out and to liaise in massive transfusions. It's usually the liaising between the laboratory and the people, or the ED department, for example. You know, there's multiple people on the phone. It's a high stress situation at both ends, and the communication is always what leads to issues. So sometimes there's replacement formulas, like you give 6 units of red cells, so I want to use I'll give 2 FFP and 2 red cells, 3 FFP, or 10 red cells and 2 platelets. A replacement formula is usually not ideal. You know, I only stock 2 platelets, so I can't actually provide something like this. You want to do serial coags, but you could get catastrophic bleeding if you're just doing a replacement formula. Or you could waste a whole lot of blood products. They don't actually need it anymore. So you do need to check. So there's been lots of ideas about massive transfusion. What's the best way to do? Do you give blood? Do we give recombinant factor 8? Factor 7, sorry, as I said earlier, that can stop bleeding. Do you give that up front instead of waiting for the catastrophic blood? Is fresh blood better than older blood? Is whole blood better? Does it matter about ABO identical? Can we give the fibrinogen concentrates? You know, there's lots of issues that unpick. There's no clear winner, and no clear winner because every trauma is different. So what we decided here was to stick to an individualised approach. So everybody gets something different. It's not, if you're bleeding, you're going to get this, 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 and this. Because we've got good medical cover, we can investigate and invest each situation, knowing what the injuries are, and our doctors can make sure that the anaesthetists and the ED physicians get the products that they need for their patients. As I said, the microvascular bleeding and hypothermia are issues. You can guide by coags or by a TEG machine. Hypothermia is pretty easy, and I'm sure you've all heard, in all the shows, medical shows on television, they put the blood on the rapid infuser and it's heated up. So in ED, they do make sure that blood goes in warm. And you can give, factor 8, factor 7. So let me just check. All right, so back to massive transfusion. We have invented a Crimson protocol in this hospital. It's because we have retrieval blood, so we have blood that sits at the airport in temperature controlled boxes that can go out to accidents on the helicopter. So when there's only 3 units in there, so when they use that blood, they come into the hospital and we call it a code Crimson, and we will have some blood and FFP up front. Now, primarily they need FFP and cryoprecipitate, because if they've had a long, if they're bad enough to be retrieved, then they're probably going to need more products. So we do get that stuff ready for them. But after that, we pretty much see how they're going and then do an individualised approach. So it is good, but if you're in a regional area, even though it's considered regional, and have a trauma situation and there's not a lot of medical support, then the rope, after 4 units of blood, 2 FFP and things like that are probably really good, because they're going to get you through. The trouble that we have is platelets, and I think a lot of people forget you don't need platelets up front. If you consider a platelet count, say, of 200, you replace the blood volume with blood and FFP, it will probably be 100 because you've diluted it in half. So you can do another dilution, a full dilution of a blood volume, and your platelet count's down to 50. And then that's getting low, but that's quite a substantial number of blood products later. So there's no point giving them too early if you don't have a lot, because you'll have none for when they need it. So in a small area like us, as I said, we only have 2. If we gave platelets up front, we wouldn't have any for when they actually needed it. So it's really important to have good protocols and understanding of how the products work. So one of the interesting things alluded to earlier, that all the products have price costs on them. And this is a couple of years old now, but we do use about $3.4 million in our blood budget. So every day we order blood and everyone gets a kick out. I did a $45,000 order or a $20,000 order. We're all considering how many shoes and handbags we could buy with that instead of blood products. But, you know, the thought was that if the blood products were on the bags, that the people would be more careful using it, which is kind of weird because it's in tiny print and I don't think anybody cares. And we get the blood budget, but when we're not responsible, we're not ordering the stuff we're giving out is provided. Although we do try and keep a handle on products, and that's where your patient blood management comes into it. And we're having our transfusion nurses or transfusion practitioners, I can't even remember the right terms for them anymore. But there's a whole lot of patient blood management guidelines. And all it is really just strategies around making sure that patients get the right blood at the right time and that they don't, it's actually required. And the line there that transfusion is a live tissue transplant is people often forget that that's exactly what it is. It's a tissue transplant. So I showed you the slide on the trick study to show that you've got you know, your mortality increased, you have more red cells. That's pretty true for everything, every procedure. I won't read all these because I'll run out of time, but you know, you've got it there to have a look at. You've got some references there. Circulatory overload is often, it's probably the biggest risk factor. It's because you're putting blood in on top of a normal blood volume, and you get fluid overload. And that's why you want to give elderly patients blood a little bit slower, because you can very quickly fluid overload them. So the circulatory overload is probably overlooked in a lot of places. So if you can reduce perioperative blood loss, and then you can do a lot. So there's the National Blood Authority guidelines using a 3-pillar module. In our hospital, we have a single unit transfusion policy. So what that means is that you give someone their unit of blood, you check that they're not symptomatic anymore. If they're not symptomatic, leave it at 1. If they're still having problems, then you can transfuse them again. Whereas in the past, you used to be, oh, let's have 2, let's have 3, and then they'd look at them at the end. So it's actually trying to assess after each transfusion if that's fine. Now that goes out the window in emergency departments or theatres. It's just not appropriate for that. It's more for the post-operative top-up or someone with post-hip surgery with an HB of 80. You know, lots of people can tolerate that, but if you're elderly, your heart's not working properly, so you may need a blood transfusion, and you may need more than that. So it's actually looking that the transfusion is doing what it's required to. So you need to look at areas that may require improvement. We always look at what our transfuse ratio is to make sure that we're not doing blood unnecessary, and it gives us an idea of maybe people are over ordering. So I won't go through all these other than there's the 3 pillars. So you optimise erythropoiesis. So it's making sure that when people go to surgery, they are not iron deficient. Okay, so the best thing, if you've got people going to surgery, make sure the iron levels are good. If you go to surgery with a low HB, you've got a greater risk of being transfused. So the next part is in theatre to make sure that you can minimise blood loss. Okay, you can do lots of different things with you can do cell salvaging, which is getting hard. You can make sure that people are the right temperature. You can do there's a whole lot of different surgeries now that have improved techniques and don't require blood. When I started in transfusion at the Alfred, when we started our first cardiac bypass, we always matched 6 units of blood for a cardiac bypass. The surgery has improved so much these days that they don't use any blood at all. So surgical techniques have certainly improved to minimise blood loss, and that will continue to go. Then you need to make sure that you can, get your reserves. So you may need to you could increase the oxygen. You need to make sure that when people have bled a little bit in theatre, that they do get some extra iron, that they generate some reserves. So they're not back next week with anemia. So we want to recognise iron deficiency anemia. We need to work out a plan. Lots of people, there's an iron deficiency algorithm. You can work it out, and this is particularly important for obstetric patients. You want to make sure that their iron status is good. There's lots of these, all of these tools, and sometimes it comes down to the transfusion people to organise this, and particularly our transfusion nurse consultants. It's even though we are transfusion scientists, we're trying not to transfuse people. So we want to have inter-op blood use. The thromboelastogram is something that we've only recently got at the Royal here, and it can guide the cardiothoracic. We're only using it in cardiothoracic surgery to make sure that we give them the product so they can. It's a little bit quicker than a coagulation test, so we can they ring us up and say we need some platelets. We can see on the TEG that it's going down. We also have one in the laboratory to use for other areas of the hospital that need it, but it is quite useful in theatre. So it's to make sure that the patients, the third one is to make sure that they're optimising their own HB. And I think I mentioned earlier about in ICU, they're sitting on HBs of 70. It's frustrating for us, so when those people step down out of ICU back to the general wards, sometimes they will transfuse these people because 70 they think is low, whereas the ICU's been really good at not transfusing them. They go to another ward and they see another doctor and they go, oh, look, they're a bit low, and they top them up. But we're trying to move. It's still we've come a long way, but it's still people doing it on symptoms rather than a number. And the awareness that transfusions are risky, and the benefits need to outweigh the risks. So just a couple to finish up with. Wisdom from new graduates. Automation. I guess you get a little bit of automation, but basically we do as little manual testing as we can. The analyzer does everything. Ours is called Bruce. You've got to have an analyzer with the name, so you've got to come up with something kitsch. So automation has drastically improved safety. If you're doing manual testing, and we're using card tube testing, we haven't done for probably 20 years. We moved to card testing 20 years ago. Automation, it removes, I think there's 100, or might have been 250 processes in a manual test system that you can make a mistake on. In automation, it cuts it down to 5. So anything that reduces risk is what we need to do. So laboratories may not have a workflow enough for automation, but on a safety level, it's a no-brainer. You just have to have one. So it's really improved our work, and basically everything goes on the analyzer. It does our cross matches, it does our panels, it does our antibody screening. We would like it to make coffee, and then it'll be perfect. Cross-matching, I'm sure you've all done cross-matching. We run on a computer cross-match. We don't very rarely do a full serological cross-match. Probably only about 5%. We'd be lucky to do a few a week at the moment. So computer cross-match, all it means is if you've got a negative, we've done a blood group, checked it twice, got a negative antibody screen, we go and grab a group compatible unit out of the fridge and issue it. There are theoretical risks. They could have a low antibody to a low incidence antigen, but it's not considered a great risk. You then have to pick out the antibody, the unit of blood in the fridge that carries that antigen. So, it's not perfect, but we've never seen a reaction happen from doing computer cross-matching. And that really frees up your workflow and having blood sitting around that's fully cross-matched. So for us, we tell the doctors in theatre, with a negative antibody screen, you ring us and we'll have the blood ready before you arrive to pick it up. So it removes blood in peripheral fridges, maybe going out of date, and it just really helps with stock control. So full cross-matching we do on people with antibodies or cold agglutinins, or anybody that has an antibody gets one. So it's not very frequent. Antigen typing, we do RH and KEL typing. We RH and KEL type all our women of childbearing age, so that if they need blood, we'll give them an antigen match. Otherwise, it's doing it exactly the way of the package inserts, using the reagents, and we'll use the cards for that. The beauty of the cards over tube testing is that doing tube testing, it's really hard for other people. You can't spin them down again and have another look. Whereas the card, I can do it and say, well, what do you think of this, and hand it to 6 different people to have a look at. And if I'm on my own in the middle of the night, I can put a bit of sticky tape over the top and it won't dry out, and it will all be good for someone to look at the next day. And if you're really keen, you can take a photo and send it home. It's amazing how many pictures I get of cards overnight. I think, wow. Or you can log into your automated computer. You can log into your analyzer from home too, if you're that keen. Not me. KELPOS units, you need to have a policy for KELPOS units. 1 in 10 people are KELPOS, which is kind of funny because we have a little KELPOS club at the Royal, and Chantel is KELPOS. She was in our KELPOS club before she left us, but one of our other new staff members is also KELPOS. So there's 6 of us out of 20 that are KELPOS, and we should only be 1 in 10. So we think that means something about transfusion. You don't want to give a woman of childbearing age an anti-KEL. It's secondary to an anti-hemolytic disease of the newborn, so you avoid KEL positive blood on women of childbearing age, and we avoid them on people with antibodies. So we don't want to give them multiple antibodies, so we give basically KEL pos blood to our little old men and women, or you can give to all of us who are KEL pos here. Scary. People used to be scared about working in blood bank, but the way the computer systems are now and the rules, there's very little to be scared of, and there's very little you can do that's wrong, unless the computers are down, and then it's not scary, you just need to concentrate. So it's now it's a very routine area, it's pretty easy, the analyzer helps you out with all your results, and the computer will make sure that you don't give irradiated blood to somebody or antigen positive to somebody. You can put in all these rules, so it really is quite a safe, unscary area these days. So this is just to make sure, you know, there's lots of resources out there. I'm sure I've got an old slide because it says Australian Red Cross, so it's now Lifeblood. Every information is on there, so if you want to donate, it's good. If you want to get talks, it's all in there. The donate blood site for there's transfusion.com on the bottom. That's where all your transfusion data will be, so you can get all information on products and phenotypes and whatever you need to know, you'll from there. It will run through education, there's tests, there's journal clubs. It's really quite a useful site to visit. And BloodSafe is the other really, really good site to do. There's lots of different modules, and we encourage all of our staff to do them. You know, the postpartum hemorrhage ones are a bit hard. We don't know much about uteruses or uteri, but it's really good information, and they're all online, and they're fun to do. So I'd highly recommend doing all those to stay educated. But what you need to do is you need to value add. Okay, like I said earlier, when you get a request for something or you get a result, you ask questions. You think, does this patient need platelet? Do they need FFP? I think this is wrong. I need to go and tell someone. Why is this person having 3 units of blood every day for a week? You make sure that somebody else knows. So instead of just taking things at face value, value add work. So go that little bit further and check, do they need this? There's nothing wrong with asking questions. So you do need to stay educated. You've only just finished, but there's a whole lot of things you need to learn, and you've got your AIMS and your APACE people. You've got your discipline societies, ANZSBT for transfusion pathology society, and coagulation societies. the general meetings have all been cancelled for this year, but they will all be going online. There's lots of scientific meetings you can go to, conferences now online, so it makes them all accessible. There's when you have staff meetings and presentations, it's great if you'll stand up in front of people and do a presentation, and it makes you learn something. To be able to present something, you need to understand your topic, and by understanding your topic, you've learned something. And reading, you've got lots of. There's no excuse. Everything you Google, whatever you need to do. Just be careful that you're actually Googling good information. Whilst I go back there, so you will be doing your placements soon, and it is a job interview pretty much. We have hired quite a few graduates. I think were they last year's, Jane, or the year before's?
I think you hired some phenomenal number this year.
Laura, and we've got a lot of graduates. And lots of them a few of them came to us as students, as you will, and then we've employed. Sometimes they need to start out in our separation area and then move into the laboratory. So your placement is really important, because if you do well on that, then you've got a leg up from any other person that applies for a job, because we've seen you, we know what you like, we either like you or we don't like you. So it's up to you how you work those. But so it's very important wherever you go, and we all do talk. So even if you go interstate, we'll find out. So don't be overawed. Just do the best you can. You may love some areas or not like some areas. Just do the best in every area that you get located in, because you may find that it is good for you without thinking about it. So that's probably all I've got, which is not bad timing. Very hard not to see you and hear you, but I think it's still doing the tour, Jane?
We didn't do the tour this year, Gina,
No,
because of COVID, and also because I'm sort of not at uni at the moment. But hopefully, COVID willing, we'll come and visit you next year.
Yes, so it's a bit hard. COVID's changed things around us. We all had to change our practices pretty quickly. So it's something we hadn't factored in. So
yeah. Okay, so I'll stop the recording.